Morning, everyone. Welcome to Department of Medicine Grand Rounds. It's my great pleasure this morning to introduce our speaker, Dr. Margot Kushel. Dr. Kushel is a professor of medicine at the University of California, San Francisco, and the chief of the Division of Vulnerable Populations at the Zuckerberg San Francisco General Hospital. She serves as the director of the UCSF Center for Vulnerable Populations and UCSF's Benioff Homelessness and Housing Initiative. Dr. Kushel received her MD degree from Yale and then completed her residency and chief residency at the University of California, San Francisco. She also served as a fellow in general internal medicine there before joining the faculty. Dr. Kushel's research focuses on reducing the burden of homelessness on health through examining efforts to prevent and end homelessness and mitigating the effects of housing instability on healthcare outcomes. Her work aims to inform the development of programs and policies to end homelessness via understanding the complex interactions between health and housing. She has a particular interest in homelessness in older individuals and in medically complicated people. She is the PI of an NIA-funded R01 that developed the Hope Home Health Outcomes in Populations Experiencing Homelessness in Older Middle Age cohort, an ongoing longitudinal cohort study examining the causes and effects of homelessness on adults aged 50 and older in Oakland, California. She's also the PI of a K-24 award from the NIA to mentor junior investigators in aging and vulnerable populations. She works with diverse stakeholders to implement programmatic and policy changes based on her research. She also maintains an active clinical practice in primary care at San Francisco General Hospital and is the recipient of numerous awards, including the 2021 Distinguished Citizen Award from the Commonwealth Club and the 2021 Woman of the Year Award from the California Senate District 9. Please join me in welcoming Dr. Kushel. Thank you so much.
Thank you so much for that introduction, and thank you all for joining me to talk about one of my sort of topics that I'm most passionate about. I want to start by just sharing a little bit about maybe the why of what I do. When I came to San Francisco in the mid-1990s to be a resident, I didn't actually intend to study homelessness. I thought I was interested in the issues of the working poor and why folks didn't have insurance. But about half of the patients we cared for on the inpatient service at San Francisco General were homeless. And we would admit them to the hospital, often to the ICU. We would, go through everything on the differential diagnosis and really provide the best care we could. And then we would have to kick them out. And kicking them out sometimes involved the intern explaining to the patient that we couldn't hold them anymore and the patient begging to stay in the hospital. We would basically make them leave, and inevitably 2 or 3 days later, they would be back and often in worse shape. And at that moment, I thought there really has to be a better way to do this. And this is what I want to understand and try to come up with solutions for, because no human being should have to be homeless. In those early years, I gave many talks and lectures about homelessness being a problem of young adults 25 to 44. It was almost a mantra in the beginning parts of my talks, but I continued to work clinically, both inpatient and outpatient. And I noticed that the people who we were caring for did not fit that description of young adults. I was working with some collaborators who had been working on a study that had been going on for years, where we had different recruitment waves. It was a study of HIV-infected adults who are homeless or marginally housed. And we would do a big recruitment wave and interview 1,000 people, HIV test everyone, and invite those who were infected into the cohort. And a colleague and I realized that we could go and look at what was happening, if this really was, if my eyes were deceiving me, or if people really were getting older. This talk is really the culmination of the work that started with that question, or really that clinical observation. So I'm going to speak about the aging of the homeless population, causes, consequences, and solutions. I welcome you, if you're interested in homelessness, to follow me on Twitter, or to follow our Benioff Homelessness and Housing Initiative on Twitter, where we try to keep out relevant information. So this is one of my study participants. I'm old and I'm tired and I got my disability. I can't do it no more. In this talk, I want to talk about why the homeless population is aging. I want to introduce you briefly to the Hope Home study, talk about the demographics of people experiencing homelessness who are older in Oakland, talk a little bit about how people wound up homeless in their 50s and later, their health status, their healthcare utilization, some things that we've learned about their mortality. And then, because this talk can be so depressing, I'm going to end with some interventions and solutions and a little bit of a call to action. So why is this population aging? So in that study that I mentioned, where we looked through waves of data, we found that in 1990, when I wasn't involved then, but when the data was collected, 11% of the single adults in San Francisco were 50 and older. When we analyzed our last wave, which was 2003, we realized that 37% were. Now, when we take a peek at data in different that are collected by different counties and things, in general, the median age of the single adults is about 50. We learned in our study that the population was increasing about 2/3 of a year for every calendar year. That's not what should happen in a stable population. So we were really curious about this. We published this paper, and the way science works is we sort of batted it over to my colleague in Pennsylvania, Dennis Culhane, who said, well, that's a really interesting question. I think I can take a stab at it. And he looked through shelter data across the United States, focusing on single adult males, figuring that they were less likely to be family, heads of family. And what he found was that Americans born in the second half of the baby boom, approximately 1955 to 1965, have had an elevated risk of homelessness throughout their lifetime. When these men, this big population, because it's the baby boom, were in their early 30s, that was the big bubble of people experiencing homelessness. And you can see that by this green line right here. If you look at the orange line, that is in the year 2000, where 1 in 5 people experiencing homelessness were born in that age cohort, or men experiencing homelessness. And then if you go to 2010, you can see that this group is 49 to 51, and they are now the big bubble of people experiencing homelessness. We can think of a lot of reasons for this. This is the second half of the baby boom. The folks born in that era had a lot of bad luck. They came of age in times of depressed wages, high unemployment for young adults, and high rental housing costs. Many of them came of age in a time of a change in criminal justice policy and high rates of prolonged incarceration, really the beginning of the era of mass incarceration. They came of age as a safety net was getting eroded through the 1980s and 90s, the decline of unionization, the rise of income inequality, and really a major change in how the federal government supported, or I will say did not support, affordable housing. Dr. Culhane and his colleagues have shown that this trend is still ongoing. Looking at 3 counties, including LA County across the country from 2017 to 2030, they anticipate that the proportion of the homeless population that is 65 and older is going to triple between 2017 and 2030, when we anticipate it will begin to come down as this population passes away and is replaced by younger populations. So why do we have such a homelessness problem? Many of you, like me, are in medicine, and many people will point towards substance use and mental health, but those are not the drivers of homelessness, nor do they explain why homelessness is higher in some regions than others. One of the main reasons we have homelessness is described in this graph. In the United States, there are only 36 units of housing that are both available and affordable for every 100 extremely low-income households. Extremely low-income households are those that make less than 30% of the median income of the area that they live in. That median income is different in San Diego than it would be in Kansas, but every area has its own median income. What I want to point you towards here are the bright red regions like California, which is actually the second worst state in the nation on this key criteria. In California, we have only 24 units of housing that are available and affordable. Available meaning potentially rentable, and affordable meaning that they can be afforded by people paying less than 30% of their income, which is the general cutoff, for every 100 ELI household. Until we start fixing this deficit, we're not going to make a lot of headway on homelessness. And no talk on homelessness can avoid, or no thinking about homelessness can avoid this undeniable fact that homelessness is a racial injustice issue and is a direct result of structural, institutional, and individual racism. Home ownership in this country is a primary means of intergenerational wealth building. But I want to remind you that until the fair housing laws were passed in the late 1960s, there was perfectly legal discrimination in home ownership, where racial covenants were allowed that created segregated neighborhoods. And then the banks engaged in a practice called redlining, which restricted Black and Brown individuals by purchasing housing in the neighborhoods that they were allowed by racial covenants to live in. This effectively excluded Black Americans from the post-World War II increase in home ownership, and is a major cause of the wealth gap that we currently see between Black and white Americans. In the late 1960s, fair housing laws were passed, but those have not successfully eliminated racism and have not successfully eliminated discriminatory housing practices. For instance, in 2008, we saw the predatory lending crisis really disproportionately impact Black and Brown homeowners who were targeted. And we know through secret shoppers and other mechanisms that despite the laws, there is ongoing discrimination in the rental market, such that if you are a Black household and you have exactly the same housing resume as a white household, you are significantly less likely to be offered a rental apartment, thus leaving Black households paying more for the same quality of housing. You add to that the well-described discrimination in the criminal justice system, in the employment system, and in the educational system. And I will remind you that we still live in these redlined areas and our public schools are funded through local taxes. It is perhaps not a surprise that Black Americans are at a 3 to 4-fold increased risk of homelessness compared to white Americans. In many cities in California, this discrepancy is even worse, with Black Americans at a 5 to 6-fold increased risk. So now I want to, with that background, switch a little bit and talk about my research. The Hope Home Studies, or the health outcomes of people experiencing homelessness in older middle age, has been funded by the National Institutes of Aging since early 2013. It is a longitudinal cohort study in Oakland. We, using venue-based sampling, meant to give us a population that best represented the source population, recruited 350 participants between July 2013 and June 2014, and we've been following them for every 6 months since. In 2017, 2018, we added an additional 100 participants to replete those who had died or been lost to follow-up. To be in the study, you have to be 50 and older, English speaking, homeless by the federal definition of homelessness when you're enrolled, but you remain in the study whether you remain homeless or not. And the HERF definition, which is the federal definition, says that people are homeless who are living outdoors in places not meant for human habitation, people living in emergency shelters, people who are losing their housing within 14 days and have no other place to go. So if you have like a quit order, eviction order, but you don't have another place to go, or if you're fleeing domestic violence with no place to go. The study activities include regular study interviews and exams, qualitative in-depth interviews on topics of interest. We add new questions frequently and adapt the study as needed. We assess things like death records from local government and the state, jail records, HMIS, or the Homeless Management Information System. We do monthly check-ins to enhance our follow-up, and we track our participants, meaning if we don't see them, we go out looking for them. We ask them to give us a list of contacts, places where they stay, and we really go out and find them so that we can talk to them. So what have we learned? So when we started the study, and this is important to keep in mind as you hear the rest of the results, the median age was 57. Remember, everyone had to be 50 to be in the study. The range was 50 to 80. And when we enrolled people, 12% were 65 and older. Most people were less than 65. And in fact, half were 57 or less. Like many studies of single adults, most were men, 77% were men. And in a city where 26% of the population identified as Black, 80% of our participants were Black Americans. 90% reported their household income as less than $1,150 a month, most much less than that. When we asked when people had lost their stable housing, and we defined stable housing as a non-institutional place that they had lived for a year or more, we found that a third had lost their stable housing in the past year. When we changed that question to when did you become homeless, because they might have not had stable housing but not been homeless, a third had become homeless during this episode in the prior 6 months. We tried to determine why people became homeless, and far and away the biggest reason was simply people couldn't pay the rent or mortgage. 28% of the sample reported that that was the primary reason why they became homeless. And of those, 7% reported that they had lost their job, or 7% of the whole sample. 15% of the whole sample reported that somebody else in the household stopped being able to contribute to the rent or mortgage, and that was why they lost their housing. Only 7% reported being formally evicted, but we think that this is an undercount because most individuals that we learned will leave before the formal eviction is on record. And why it's really important to note that using eviction as a stand-in, or eviction prevention as a stand-in for homelessness, can be problematic. The other thing is that most didn't go directly into homelessness from eviction, and many, in fact, doubled up with others. And so when they actually lost their housing, it was not from an eviction. So how do people wind up homeless after the age of 50? So if you remember one slide from this talk, this is the one. So everyone can sort of just look carefully for a minute and then go back to drinking your coffee if you need to. Remember that everyone in the study was 50 and older. But of everyone who was 50 or older and homeless, a full 44% had never been homeless, not even for one night before the age of 50. If people were homeless for a night or two, they show up in the bar at whatever age that happened. You can see that an additional 19% were never once homeless until their 40s. So we asked ourselves, are those who first become homeless late in life different from those who first become homeless earlier and remained homeless? Those who were homeless before the age of 50 and remained homeless after 50 had extraordinarily terrible early life adversity. That did not set them up well for adulthood, and they reported low income attainment in early adulthood. Most reported having no spouse or partner, mental health problems that started early in their lives, high traumatic brain injury, high imprisonment in state or federal prison, and alcohol use problems that started early. When we compared these to those who are homeless later in life, these remain statistically significant in multivariable analysis. This was a story of one of our participants who reported that he became homeless when he was in his late teens and had been homeless, incarcerated, and really never fully housed until now when we met him when he was in his mid-50s. Here he is talking about the night that he first became homeless when he was 15 or so. My father said, next time, if you run away, I'll beat you with a car chain or I'm going to throw you out the window. Okay, so I wouldn't use the word reasonable, but I put things in perspective real quick. And I would say, could I survive a car chain? Probably not. Then I looked at the window and said, and we lived on the 13th floor. I said, I ain't playing with this man. He went to work. I had whatever I had on me, and I was out the door. This began this young man's journey into homelessness. And there he was living on the streets of Oakland about 40 years later. The stories of those who became homeless late in life was very different. In general, these individuals had worked throughout their lives at important, hardworking jobs, but that paid very low wages. They did so until something happened, some crisis and sometimes two. And that crisis was either the loss of a job, the breakup of their marriage, their own illness or their spouse or partner's illness, their spouse or partner's death, or their parent's death. I can't tell you how many people we met who were living with mom, who then passed in her mid-70s, and they did not have their name on the lease. They did not have title to the house, and they found themselves grieving and frightened out on the street. I can tell you that this has changed my end of life counseling practices with my older patients, where I ask them, among their concerns about dying, are they concerned that a family member will become homeless? We found with these individuals who were homeless late in life a profound lack of advocacy. Basically, they knew what was happening, but nobody was there to help them. Many were evicted for reasons other than non-payment of rent, where they actually had legal rights to stay in the house, but did not exercise those rights because they were not aware of them and did not have legal protection. They were not getting benefits, which they had earned or deserved. And everywhere they looked, they faced bureaucratic hurdles. They had low social support, not so much that they didn't have friends or family, but they were so deeply ashamed about what was happening to them and so stigmatized by the thought of becoming homeless that they didn't tell anybody. They were less likely than those who were homeless early in life to have imprisonment or long incarcerations as part of their history, but they reported to us the many ways that their housing and jobs had been hampered throughout their lives by one-time charges, often one-time drug charges or unexplained arrests that had happened early in their lives. This is a man speaking. He was part of a couple who we discovered under an overpass when we started our study. It was a lot of different things, but basically the new owners took over. We were being evicted. My wife, she had just got out of the hospital, had the stroke and was blind. So the daughter came up and said, don't fight it. Y'all can come stay with me for a couple of months and save your money. So we said, okay. They didn't fight the eviction. After we moved out of the place, turned in the keys and everything, we went over to her house and she said, y'all can't stay here. It turned out her boyfriend wasn't excited about having his girlfriend's blind mother staying with them. And I said, I've got $9 in my pocket. I said, at least let your mother spend the night because we don't have enough money to get a motel room. She said no. So that was the beginning. They stayed outside for about a year or two until they finally were placed in senior housing, and the wife died soon after. While those with late onset homelessness tend to have fewer vulnerabilities, many had significant health challenges related to their homelessness. 56% of our participants reported that their health was fair or poor. This number is similar to those we see in populations of people in the oldest old, 85 and older, but it's very unusual to have 56% of people report their health being so poor. Self-reported chronic diseases were very common, but we suspect that they were underreported because people had poor access to healthcare. I just want to point out a few things. This was in enrollment in the study with a median age of 57. And you can see that 7% already had a diagnosis of CHF, 7% already had a heart attack, and 11% already had a stroke when we invited them into the study. 14% knew that they were living with diabetes, and we know that that is a disease that is very under-recognized. high proportion of our participants had functional impairments. Almost 40% reported at least one limitation in activities of daily living, and most of them reported 2 or more. Similarly, 50% reported at least one limitation in instrumental activities of daily living, with about half having 2 or more. We conducted some neurocognitive tests and found a very high prevalence of cognitive impairment. Over 25% scored in the range of moderate to severe impairment on the 3MS measure of global impairment, and 35% had evidence of impairments in executive function by the TRAILS-B. And as a reminder, executive function is the ability to follow complex sequence of tasks, such as if you want to get housing, you need to go to this office on Mondays before 10 and pick up this paperwork and then bring it to that office. That's exactly the kind of thing that someone with executive impairment cannot do, but that's what our participants were dealing with. We found a high prevalence of all geriatric conditions: mobility impairment, 1 or more falls in the prior 6 months, visual impairment, hearing impairment. Nearly a half reported urinary incontinence. Now imagine trying to show up to compete for a rental housing or a job if you don't have access to clean your clothes and you have urinary incontinence. All of this leads me to say that when we talk about homelessness, 50 is the new 75. The median age of our sample was 57, but the prevalence of geriatric conditions were worse than those we see in the general population samples in their 70s and 80s. Now, substance use for sure was common. 65% qualified for on the assist tool as having moderate or severe substance use problems, with the most common problems being in cocaine, with 43%, 13% with opioids, and 8% amphetamines. I will say many of them spoke to us about how their substance use worsened when they became homeless. 26% had moderate or severe alcohol use symptoms measured by the audit, with 15% qualifying for severe symptoms. Mental health problems were also common. Over 37% qualified as having depressive symptoms that were moderate to severe severity on the CESD. Over a third scored 3 or higher on the PTSD screener. 18% had ever been in a psychiatric hospitalization, and 5%, when we met them, had been in a psychiatric hospital in the prior 6 months. We looked at health services utilization. Despite how sick they were, the good news is that people had relatively good engagement with primary care. And remember that we started this in 2013, right as the ACA was rolling out. I think this speaks to the safety net and the relatively robust safety net in Alameda County, where the study took place. But 72% of participants were able to name a clinic or a doctor's office where they had as a non-emergency department source of routine care. 53% were able to name an individual primary care provider. Despite that, however, half of all participants visited an emergency department in the prior 6 months. And I will tell you that we chased down records and we found these records. So we think, if anything, it's an underestimate because we only counted it if we found the record. Despite that, it was less than 7% of participants who accounted for half of all the ED visits, or this small group of high utilizers who were really making the majority of the ED visits. A full 10% of our participants were hospitalized for a physical health condition just in the prior 6 months. Extraordinarily high rate of hospitalization in a population whose median age was 57. We have followed the population all this time, and I want to share some results. One is that our mortality rate is shockingly high. We have identified 104 deaths of those original 450 participants from the 2 waves. The median age of death is 64, with a range of 54 to 77. Of the original 350 participants who we enrolled in 2013, 2014, a full quarter of them have died. We have 16 deaths among the 100 people we recruited in 2017, 2018. The rates are greater than expected. When we compared standardized mortality rates to Oakland, the surrounding city, we found that the death rate was 3 times higher than expected for men, and 5 times higher than expected for women. The top 3 causes of death were heart disease and cancer, with about 15 and 16%. And then the next leading cause was drug overdose. I will say in other studies of homeless populations, they have not found a drug overdose death, but most studies that you read published on homeless populations are studies of people engaged in health services for people experiencing homelessness. We actually engage people whether they're in encampments or on the street, and whether they're engaged or not. And I think that this might relate to why we had such a high rate of drug overdose death. When we looked at predictors of mortality in a multivariable model, one of the strongest predictors of dying was being first homeless after the age of 50. So do you remember those 44% of people who had their first episode after the age of 50? They, it turns out, were much more likely to die with that adjusted hazard ratio of 1.59. Those who were homeless at a follow-up interview as compared to housed had an adjusted hazard ratio of dying, elevation of 1.62. Those who were in institution, mostly a skilled nursing facility, had an adjusted hazard ratio of 3.25. I think of this as effect cause. People became very ill, went to skilled nursing facilities, and that was on why they died, is because of their illness. Diabetes and liver disease were independently associated with an elevated risk of mortality. So now that I feel like I have everyone completely depressed, I want to turn a little bit to what to do. So the first thing is, the solution to homelessness is housing. Housing first is the evidence-based approach to serving homeless individuals. Housing first is not a specific program, and it is not housing only. You might have read about it in the press. There's quite a bit of controversy about it, but there is an amazingly strong evidence base for this. What the evidence base supports is an approach that prioritizes safe, permanent, affordable housing as the foundation, and that it does not require engagement in services or any other prerequisites before people are housed. This is the best way to end homelessness, and this works. What I like to say is that everyone needs housing. Some people require services to stay in that housing, and some people don't. Some people who require services require a lot of services, and some a little. We need to match those services to people's needs. But for housing to work, it must be offered without precondition, and it must be affordable. If you ask desperately poor people to spend more than 30% of their income on their rent, they are not having enough money set aside for food, for healthcare, for transportation, or for any other basic needs. You might say, well, what about those folks with really significant mental health and substance use challenges who I see in our emergency departments and in our hospitals? They don't really seem like they could cope on their own. There is a very well studied, and I've done several of the studies, and I'm happy to review the evidence, very well supported intervention that is enormously successful at providing housing for these individuals. For those with chronic homelessness and disabling conditions, the answer is permanent supportive housing. What permanent supportive housing is: subsidized housing that are with linked supportive services that are voluntary and that meet the need of the individual. Some people need a 1 to 15 ratio of a master's trained case manager. They need vocational services. They need substance use support, and others. Some people need, a 1 to 30 ratio of a case manager, helping them fill out forms, making sure that they don't have any problems paying their bills. These services to work must be voluntary. This is what's called the housing first model. You start with the housing, and then you try to engage people in everything else you have on offer. What you've learned is if you do that, they do take you up on the offer and they do stay housed. It's shown to be highly effective at keeping people housed. We've done studies with the most impaired people, the people who face the most barriers to housing, people who are cycling through psychiatric hospitals, psychiatric emergency rooms, hospitals, emergency departments, and jails, who have multiple co-occurring both psychiatric and substance use disabilities. And we found that housing first with a permanent supportive housing model can keep upwards of 88 to 90% of those people housed over the long term. We will need to adapt these services for the needs of older adults. Many of the folks in my study will need personal care attendants, will need modifications to be wheelchair accessible and the likes, but we need to do it and we need to get them housed first. We need permanently affordable housing. Many older adults who are homeless do not require permanent supportive housing, but they do require housing that they can afford on limited income. Things like housing choice vouchers, or the program commonly known as Section 8, only currently serves 1 in 4 eligible households in this country. We cannot solve the homelessness problem without fixing that. We need senior housing. There's some new interesting studies, projects being done with shared housing, where small houses are bought and 3 to 5 individuals are put in with their own bedroom, but that they share the housing and thus share the rent to decrease the cost. And we desperately need to produce, protect, preserve ELI housing. And we need healthcare providers' voice in this fight. I want you all to be aware of the term ELI housing, which I've used several times. We need to expand and preserve affordable housing. As I've said, ELI stands for extremely low income housing, which is housing targeted towards the needs of those who make less than 30% of the area median income. And I want to introduce you to some great sources of information about this: the National Low Income Housing Coalition and the National Low Income Housing Coalition in California. You can see in California, we have 21% of our renter households are extremely low income, and we are short almost 1 million rental units to provide the housing that those individuals needed. Right now, households in California need an annual household income of $77,000 to afford a HUD fair market rate 2-bedroom apartment. That is obviously way out of reach for most of our low-wage workers or people living on disability. A full 76% of ELI households in California have a severe cost burden, paying more than half of their income in rent. We also need to think about preventing homelessness. When you think that 44% of the individuals in our study were never homeless before the age of 50, and that those individuals had extraordinarily high death rates, we need to think about how we stop homelessness before it starts. And this is a little bit of a complicated graph, but I want to just walk you through it. When we want to do homeless prevention, I sometimes will hear programs touting that they prevented 100% of homelessness, and I think they probably didn't target the right people. To actually be effective for homelessness prevention, you need to target the highest risk people, some of whom will become homeless. It turns out when you give people sort of freedom to say, when you give like frontline workers to say, who do you think will benefit from housing prevention, homelessness prevention, which is often paying rental arrears or doing landlord negotiations, they tend to choose people who are at lower risk of homelessness. If you look at this chart of what happened in a homelessness prevention program in New York, they assessed the risk level. Risk was things like substance use, prior homelessness, other things that would make you more likely to become homeless. Those who had lower risk levels did not tend to become homeless, which is the y-axis here. But to be honest, they didn't become homeless whether they got the intervention or whether they didn't get the intervention. What you see here is the solid line is people who did not get the intervention, and the dotted line is people who did get the intervention. If you just look at the outcomes of people who did get the intervention, it looks pretty bad when you go up to those higher risk folks, because a lot of people became homeless. Except what you see a widening of a line or the impact of the intervention. You really have to look at the counterfactual. And it turns out if you want to prevent homelessness, you need to provide services to super high risk people. And you have to recognize that it won't always work, but that's how you know you're making a difference. What are some of the best indicators that people are at high risk of homelessness? For single homeless adults, there are really two things that blow everything else out of the model. And that is whether they've ever been homeless before, or if they're living in a high area deprivation index census tract, basically a formerly redlined area. If you take these into account and you find people who are behind in their rent, who say that they're likely to become homeless, who are facing eviction, these are the people we really want to concentrate our limited resources on, to throw resources at them so they don't then become homeless. In California, for older adults, there is now a program that's undergoing a massive expansion that I want you to be aware of. It's called Home Safe, where every adult protective services unit across the state is now going to have significant resources to do homeless prevention for adults, older adults, and those with disabilities who were referred to them for concerns about self-neglect, abuse, or any other qualifying form from APS a referral. These services include things like money for rental arrears to catch people up in their rent, case management, moving costs, negotiations with landlords. They can do cleaning of people who, help them clean out apartments for people who are, let's say, hoarders and getting evicted, or other things. It's a really phenomenal program that is available to people who are at risk of homelessness and referred to APS for a qualifying APS condition. So as I wrap up here, I just want to say that homelessness is reaching crisis proportions. The aging of the population increases the urgency of this. The suffering we see is immense. The use of the healthcare system can be chaotic. And while mental health and substance use disorders are common, the underlying causes are structural. Everybody needs housing that they can afford. Some just need the housing. Some need services coupled with that housing. And we need all housing for older adults, whether permanent supportive housing or otherwise, to be age friendly. I want to ask you to share my tagline, that there is no medicine as powerful as housing, and to join me in the fight for a more just California that provides housing for all. And with that, I'm happy to stop and take some questions. Here's my contact information, by the way. Put the QR code back up, and happy to stop and take questions.
Dr. Kushel, thank you so much for that very thoughtful, thought-provoking, and inspiring presentation on this very, very important topic. We are really grateful to you. I particularly appreciate the call to advocacy that you have made to us. I think that that's such a critical piece of our role as physicians, and one that we, I think, sometimes don't always feel as comfortable embracing, but is so critical for our patients. I want to encourage everyone to use the Q&A tab to ask your questions. I know this is the part of being virtual for Grand Rounds that's always the most challenging. Can I ask you, Dr. Kushel, have you had the opportunity to look at the impact that the COVID pandemic has had? I know that that may be beyond the scope of your current talk, but I know that we are seeing many people impacted in lots of ways, but particularly with respect to housing.
Yeah, we've seen it's been a really sort of harrowing and interesting time. At the beginning of the pandemic, we were really worried about sort of mass death, basically. These older folks with the really high prevalence of the comorbidities that we already knew were going to cause, increased morbidity and mortality. We're also really worried about flattening the curve. We know that for people experiencing homelessness, we often have to lower our admission thresholds. They stay in the hospital longer We weren't going to be able to discharge people, with COVID back to shelters. We had all these concerns. So early in the pandemic, I was involved with the state of California in setting up this program, Project Room Key, which did two things. It basically provided non-congregate shelter to people who were either older or had COVID sort of qualifying conditions, things that were, transplants or other things that made you at high risk for a poor outcome. And then also provided isolation and quarantine opportunities. And much of California really embraced this in a big way. And that helped get a certain number of people, off the streets. It also helped to de-intensify shelters. San Diego did something interesting, which they didn't do as much Project Room Key, but they set up the convention center and tried to do ventilation and other testing and other safety measures. At the same time, we were incredibly afraid that with the economic disruptions, many more people would become homeless. So there's sort of like good news and bad news story. In some ways, our fears about shelters being conduits of infection turned out to be true. You see all over San Diego had multiple, we had many in San Francisco, these terrible mass outbreaks, even before Omicron, right, where 75% of people got infected. So that was terrible. In a weird way, because in California, 2/3 of people experiencing homelessness are unsheltered. Turned out being unsheltered was relatively protective against COVID because of the ventilation about being outside. So we maybe saw a little bit less of an impact than than our worst fears were. And in many places, they really did exit the high-risk people out of shelters pretty early. We've had very strong eviction prevention protection laws where basically there was layered federal, state, local eviction prevention. Those things are just being lifted now. But as they've been in place, we really think that it prevented the mass evictions that we were afraid of. The other thing is in the federal sort of COVID responses, there was more money that came into the homeless system than we've ever seen, more money than in decades. And that money has been able to be used to actually do things like pay for housing, exit people from homelessness. We've seen things like the changing of Project Room Key to Project Home Key, where many of those hotels and things are getting bought for permanent housing. So I would say in a way, it wasn't good news, but it was perhaps less bad news than we thought. Sometimes I sort of hear people say oh, we shouldn't have been so worried. But the point is there was less bad news because there was governmental sort of intervention, both in eviction protection, in Project Room Key and other measures. The shelters remained, and to be honest, remain today extremely unsafe in terms of high levels of COVID.
Thank you so much, Dr. Kushel. Certainly an unexpected silver lining.
Yes.
From Dr. Mohammed, we have a question. Thank you, Dr. Kushel, for this important research. As you know, the veteran population is at high risk of homelessness, perhaps due to prior trauma. Can you comment on the statistics on homelessness pre and post Vietnam War, and also on the role that the forever wars have played in increasing homelessness?
Yeah, that's a really terrific question. So veterans, particularly particularly Vietnam era veterans, are at particularly high risk for homelessness. It turns out, looks like women in just about any conflict or in the military in general are at particularly high risk. And for men, it was really those Vietnam era veterans who are at particularly high risk. Certainly trauma, and that trauma includes military trauma, military sexual trauma for the women has been invoked as a common thing, but certainly trauma has played a major role. And of course, in this country, we are not equal opportunity who we send into the military. So it's often folks who don't have the family wealth, that go into the military, which also probably increases the risk. I will say that the shining light of this is that there is some political will to house veterans that we cannot seem to gather the political will for other people. And at a time where homelessness has increased really dramatically over the past few years, it's gone down by half in veterans, by the VA really funding and staying true to this housing first, permanent supportive housing for those who need it, what's called rapid rehousing or sort of short-term housing costs, homelessness prevention. The VA, for anyone who works in the VA, knows that they screen everyone for homelessness. If you have those indicators of either being homeless or at risk of homelessness, you immediately get referred, and they have the resources to do it. No one should be homeless in the United States, but certainly no veteran should ever be homeless in the United States. There's still a long way to go. But if the veterans hadn't done what they did, we would have seen much larger increases. But as you say, as veterans make up such a large part of the homeless population, the fact that homelessness has increased despite veterans decreasing means it's really increased a lot in everyone else. But absolutely, this endless war, not to mention all of the resources, the federal resources that would take, we could fully fund our housing choice voucher program for its estimated, $70 billion a year or something, which sounds like a lot of money, but it's really a rounding area for the federal government. They could turn the switch and decide to fully fund housing choice vouchers, which would have a completely transformative impact on homelessness, but we can't get it passed through Congress. And you have to think about all of the money that we spend on this sort of endless wars as well. So thank you for that question.
Thank you, Dr. Kushel. From Dr. Jiang, one of our chief medical residents. Thank you for this thought-provoking talk. As a Suitcase Clinic alum, this is a population that is near and dear to my heart. What are ways we as the medical community can use to engage and retain the chronically and newly unhoused in care?
Great question. So I think, I think there are multiple answers to that. One is obviously being involved in setting up, and sort of staffing and setting up the services to support, obviously, the interventions. It's very hard to engage people in care when they are still homeless. But I would say we can't just abandon, obviously, the people who are still homeless. And we really need to think about how much of our system is really unworkable for people who are homeless. The demands we make on people of sort of showing up for your appointment on time, at a certain date. People feel, when we talk to folks experiencing homelessness, they talk about the stigma they feel, and the shame they feel, and the blaming they feel in the health system. And so we really need to interrogate how we address people and treat people, how we set ourselves up, that the places that have done care for people who are homeless better usually have open access scheduling. So you can come whenever you come. You don't have to make an appointment, because making an appointment is a super hard thing to do. That are trauma informed, recognizing the extraordinarily high rates of trauma in this population, that take harm reduction approaches to engage people in care, and that the need for doing street outreach and bringing the care to where people are, both as a way to keep people alive, but also as a way to engage people and build trust in the system, is so important as well. I would say for the newly homeless folks, you probably are caring for them and don't realize that they're homeless. And, I have integrated standardized questions that I ask every patient, that I normalize it. I say, housing is really expensive in San Francisco. How's it going for you? And I just sort of open up a conversation. And I found so many of my patients are living in their cars, are, couch surfing, or are sleeping outside, but haven't told anyone. So I think it's also just important to ask, but then I actually do, I do share decision-making, to be honest, of whether I chart it, because I have made the mistake of putting the ICD-10 code in, and then my patient gets their after visit summary and is like, I'm not homeless. Why are you saying I'm homeless? I sleep in my car, but I'm not homeless. It's a very stigmatized term. So I usually have that conversation with people before I just put it into their record.
Such an important reminder. Thank you. And from Dr. Sip, one of our chief residents, such an amazing and thoughtful talk. Can you comment on the new movement of tiny homes and how that can play a role in securing more permanent homes for at-risk populations?
Yeah, I mean, I think of the tiny home movement as sort of non-congregate shelter. I really hope that we start moving beyond congregate shelter, which can be very traumatizing for people. And you often get people who are like, I'm not going to go there. And then we interpret that as they don't want housing, but they don't feel safe there. And so the advantage of something like tiny homes is that it's a form of non-congregate shelter where they can be sheltered, but they can have like a door that locks of their own. We are involved in the Bay Area, in the 9-county Bay Area region, in trying to push this 1-2-4 policy, which is that for every instance of interim shelter, which is like a tiny home, you are developing 2 units of permanent housing and 4 episodes of prevention. Because if you put all of your resources into interim housing, then then people just go in there and stay there, and then there's no place to go, right? And so they pile up, and there's sort of no flow through the system. We are likely always going to need an emergency response for homelessness, but we really need to be digging into those permanent solutions. But I think in terms of interim solutions, tiny homes, make sense because they're non-congregate. They give people more safety and privacy. We talk about the 4 Ps: privacy, pets, possessions, and partners. That you have to give people the autonomy to bring their pets, their partners, their possessions, and have privacy to have them choose it. People don't need interim housing. Like if we had, in the sense that if we had, like, you don't have to go through it to get to permanent housing, but since we don't have the permanent housing, it's a good way to flow people through the system. I think that it makes more sense than some of the big congregate shelters, which can be so traumatizing.
Thank you. From Dr. Moore, our Chief of Geriatrics and Gerontology, thank you for this excellent presentation. Do you think that those who are at higher risk for death due to first episode of homelessness at older age are at higher risk because they're in some way less resilient compared to those who are chronically homeless?
That is a really great question, Dr. Moore. We're just been thinking about this, and I think it's our hypotheses at this point are one of a couple things. One is the folks who are first homeless before, there's such high death rates in homelessness that the folks who were homeless before and are still alive are probably, more resilient people in some way or another, right? That they still survived. They've been homeless for a while and they still survive. So that's a sign of resilience, perhaps. I think there are 2 other things. One is this health shock theory, that these were folks who, when we talk to them, they were often folks who were in care, let's say on blood pressure medicines, on, diabetes medicine, and then they lose all their medicines because when they become homeless, everything sort of falls apart. And so they have spikes in blood pressure or other similar health shocks. I also think that they're really just terrified. They don't know how the system works. They've never heard of a shelter. Like they just really are they're really just terrified and don't have that resilience from learning the system. The third thing, though, is really depressing is I think that illness was often on the pathway to their becoming homeless, which is really horrifying when you think about it. We had so many people who had a stroke. They were a laborer. They had a stroke. They lost their job. They didn't get signed up for any kind of disability payment, or their disability payment wasn't enough to keep them housed. They had a diagnosis of cancer. Sometimes they didn't have the diagnosis, but they were feeling sicker and sicker. They were missing work. They were fired. It turned out to be their cancer. So I think it's probably a bit of selection bias, a bit of this resilience health shock, and a bit that their illness that led to their death was on the causal pathway to their becoming homeless.
Thank you. From Dr. Rubin, follow up on the question of trauma. I'm uncertain how mental health issues factor into your analysis. I would have thought this would be much more important in the aged population.
So certainly mental health is a major issue, but like most studies of homelessness, the major health issues are actually depression and PTSD. Clearly, there are people with psychotic diseases and other major mental health, major sort of psychotic disorders as well. But in this population, we saw a little bit less of that. We saw a lot of dementia. And a lot of severe disabling depression, a lot of trauma. I didn't present the data on it, but we've seen incredibly high, just shockingly high rates of victimization while homeless. And so people had trauma that led to their homelessness. They're traumatized again and again. These folks are super vulnerable, right? They're out there, they're old, they're frail. And so there's a lot of sort of PTSD, depression, and then there's incredible sleep deprivation. We've done a bunch of work now on sleep, and the people get very, very little sleep. They have all the signs sort of sleep deprivation. And so mental health is a big concern, but maybe not quite in the way that the public thinks about it. There, a good 5-10% of folks have sort of pretty significant psychotic disorders, whether some of that is sort of a psychotic depression or untreated bipolar disease versus a primary schizophrenia or something, but a lot of complex trauma and depression. And that, I think, really plays into people's also just their deactivation. I think it plays into their poor executive function. Some of it is probably is secondary to depression as opposed to a primary cause of executive dysfunction.
Dr. Kushel, thank you again so much for joining us and sharing this important work with us. We're so grateful to you. And I hope that all of you will join us again next week for Department of Medicine Grand Rounds.
Thank you so much for inviting me. Thank you. Bye-bye.
It was truly our pleasure. Thank you.